And welcome to another intensive care at home live stream. Today's topic is how long can you live on BiPAP or CPAP at home? It's a question we get rather frequently, and I thought it's time to do a live stream about it so I can give you again some real world case studies. So just a couple of housekeeping issues. If you have any questions regarding today's topic, please type them into the chat pad. You can also dial in live into the show if you wanted to. After I go through the topic, then it's time to answer questions. If you have any topics that are intensive care or intensive care at home related, but not on today's topic, I'm very happy to answer them as well. Once I've gone through today's topic, I will let you the phone numbers know at the end of today's topic. Now, before I dive into today's topic, in case you wonder what makes me qualified to talk about today's topic, I am an intensive care nurse by background. I have worked in intensive care over 20 years in 3 different countries. I was part of setting up intensive care at home in Germany over 20 years ago, where we were the first provider pioneering what was then a new model. I also started then eventually intensive care at home here in Australia in 2012, and we are serving a large number of clients here in Melbourne, Sydney and Brisbane for intensive care at home, and we're employing intensive care nurses in the home. We are the only service in Australia, as far as I'm aware, that has third-party accreditation to provide intensive care at home service. We have built not only the quality manual, but also the accreditation and the intellectual property to provide such a service and take clients home from intensive care directly and keep them safe at home and provide them, more importantly, with quality of life. Some of you may also know me from Intensive Care Hotline, where we provide a consulting and advocacy service for families in intensive care, and you can find more information there at intensivecarehotline.com. Some of those live streams, like today, are about intensive care at home, and some of the live streams are about intensive care in general. But today, let's focus on the intensive care at home topic. How long can you live on BiPAP, CPAP at home? So the answer to that very question is really that it depends. We've had some clients at home that have been at home on BiPAP or on CPAP for many years, and we had some clients at home that have been on BiPAP just for a few weeks or for a few months for palliative care, and those clients eventually passed away, even though they were at home on BiPAP. It was their desire to pass away at home. They didn't want to go back in hospital, and we obviously facilitated that with 24-hour intensive care nurses at home. And just on that note, all of our nurses that work for us have a minimum of 2 years ICU experience or pediatric ICU experience. Most of them have completed a postgraduate critical care nursing qualification. The average nurse that works for us has probably between 8 and 10 years ICU or pediatric ICU experience. We, as a matter of fact, employ hundreds of years of intensive care nursing experience that we send into the community. And that is something that I'm very proud of, but also something that's unmatched as far as I'm aware in the industry, that anyone can send highly skilled intensive care nurses into someone's home and keep those patients or clients at home instead of having them in an intensive care unit that's full of infections, that's busy, that's noisy. There's still limitations around visiting hours because of COVID. I could go on about why intensive care at home is the much better alternative compared to an intensive care unit, especially when it comes to long-term stays or long-term treatment on life support. So looking at some case studies, our very first client we actually took home on BiPAP in the very early days of the inception of the service was a 3-year-old boy at the time. he was born with a very rare disability, and then he ended up having a cardiac arrest at the age of 3, and he ended up with a hypoxic brain injury because obviously he had a period of time for more than 3 minutes where his brain had no oxygen and irreversible brain damage was caused. So eventually, he spent like 6 to 12 months in the pediatric ICU before we could finally take him home on BiPAP ventilation. He also had seizures as part of his hypoxic brain injury, so that he had a very unstable airway and was on BiPAP. Now, eventually, after about 12 months, he got wind of the BiPAP because his condition had improved. He got more alert, his seizures were more controlled, and also he eventually had a tonsillectomy, and that enabled him to get off the BiPAP. So that was our first client that we looked after at home on BiPAP. And then as time went on, we looked after many more clients, and we still have at the moment, probably about 4 or 5 clients on our books that have BiPAP or CPAP at home. So one could argue, why do they need an intensive care nurse if they are on CPAP or on BiPAP at home? Well, the reality is that if those clients were to go into hospital with their chronic conditions of, for example, cerebral palsy, motor neuron disease, muscular dystrophy that gets them connected to the BiPAP almost 24 hours a day. If those clients were to go into hospital, because if they wouldn't have intensive care nurses at home 24 hours a day, if those clients would go to hospital, they would go into intensive care anyway, because the BiPAP or the CPAP couldn't be managed on a hospital ward, because again, it's an intensive care nursing skill or intensive care skill to look after those patients, even though they're chronic and long-term patients. It's not a skill outside of intensive care that nurses have to look after patients on BiPAP. Now, bear in mind, when someone is on BiPAP, again, they have an unstable airway. They need to be assessed on a shift-by-shift basis in terms of air entry. Right? Someone needs to listen to their chest. Someone needs to monitor their oxygen saturation regularly. Someone needs to monitor the volumes that are going in and going out. Someone needs to monitor whether the pressures are still appropriate for the clinical condition that we're dealing with. So when someone is on BiPAP, for example, a sort of a common setting would be an IPAP of 16 and an EPAP of maybe 10 or 8. That means on inspiration, the pressure is 16 centimeters of water, and on expiration, it's 8 centimeters of water. Now, that's fairly high pressure that goes into the lungs, especially if there's secretion buildup, if there's an infection, there's a risk, for example, for a pneumothorax or a barotrauma, and that all needs to be monitored. Now, whilst the risk is reasonably low, it needs to be picked up on very quickly, right? So that's one of the many reasons why someone needs an intensive care nurse 24 hours a day when they're on BiPAP. On top of that, most of our clients, again, with cerebral palsy, not so much with muscular dystrophy, but especially with cerebral palsy that are BiPAP dependent, they also have seizures that need to be managed. Now, so the risk of seizure management and BiPAP is a big risk for, again, aspiration. When someone is seizing, they're often having vomits as part of that, especially if they're tonic-clonic or gros-mal seizures. They, are at high aspiration risk, and therefore an unstable airway and the aspiration risk needs to be managed by someone who knows how to do a deep suction. Now, when you look at skills such as a deep suction, you might need to use a nasopharyngeal airway. You might need to use a Guidel airway. And again, those are tools and those are skills that only intensive care nurses or emergency nurses have. right? So that is one of the many reasons why there needs to be an intensive care nurse 24 hours a day. Now, some of our clients, not all of those clients, but again, when it comes to sort of long-term BiPAP and aspiration risk, they might have a fundoplication. For those of you that haven't heard of a fundoplication, it's basically a narrowing at the end of the stomach, at the connection between the stomach and the esophagus, so that it's a narrowing of that entry, so that aspiration is less likely, because there's less reflux, right? Also, when someone is on BiPAP, the pressures that go into the lungs are enormous. You know, I just talked about, as an example, 16 inspiratory support and 8 expiratory pressures, right? We have a client, I believe he's on 24/16. Now that's massive. Now this particular client does have a fundoplication, which means his aspiration risk is already diminished, but you know, it's not eliminated altogether, just, you know, it's just minimized. And especially with such high pressures going in, again, the risk of barotrauma of a pneumothorax is real, and it needs to be monitored constantly. The volumes need to be monitored. Again, chest auscultation with the stethoscope needs to happen quite frequently, making sure that air is going in properly. Oxygen saturation needs to be monitored all the time, and that is simply nothing that can be done by lay people or by even by general registered nurses who haven't worked in intensive care. You know, anything that's related to BiPAP, CPAP ventilation needs to be managed by intensive care nurses. Now, with the exception, and we're not going to talk about this today, but with the exception of sleep apnea, especially if people are otherwise healthy and they just need a little bit of CPAP overnight because they've got sleep apnea. But in our situation, our clients are not suffering from sleep apnea. If they do suffer from sleep apnea, that's probably one of the least of their concerns. They have much bigger issues to deal with. Other clients that can be looked after at home on BiPAP or on CPAP is, of course, COPD clients, COPD or asthma clients. They often need the BiPAP or the CPAP to keep CO2 levels down. I mean, that's pretty much the case for all of our clients. Manage CO2 levels, carbon dioxide levels, as well as PO2 or oxygen levels. I mean, that's often the whole purpose of the BiPAP. And I'll give you another example again. That was a client from one of our earlier days. That was a C4 spinal injury client. She was on BiPAP, and what happens is, if people are not getting the BiPAP regularly, their CO2 goes up, and if their CO2 goes up, they become confused. Now, when patients are confused or clients are confused and they're becoming non-compliant, they may not take their medication, they may not eat, they may not drink, they may become incontinent. You know, there's all sorts of issues coming from by people not being compliant with the BiPAP or the CPAP at home. And again, if you're working with professionals like we do, you know, we ensure that compliance is there, and we explain obviously to people that why the BiPAP is necessary or the CPAP is necessary, and it just gets clients to experience a much better quality of life. Again, another example is we have a client where we do night shifts only, and this client actually has dementia, very dementious, and if she's not on the CPAP overnight, she doesn't need the CPAP during the day, but if she's not on the CPAP overnight, again, her CO2 rises, and she would be even more confused during the day. You know, there are false risks, right? Massive false risks, and that gets people into hospital anyway. I mean, part of the whole idea about our service is really to keep people out of ICU, offload the hospital system, you know, making sure that an already stretched hospital system doesn't get more overloaded. Now, also, where's the evidence for all that I'm telling you? So some of the evidence you will find in the mechanical home ventilation guidelines that we publish on our website. I will put a link below this video once it's published for everyone to watch. So when you look at the mechanical home ventilation guidelines, again, they are guidelines from over nearly 25 years of intensive home care nursing now, out of Germany and now also out of Australia. And those are evidence-based mechanical home ventilation guidelines. And those guidelines clearly say that the only way it's safe to take someone home from intensive care on BiPAP, CPAP, tracheostomy, so even on non-invasive ventilation, needs an intensive care nurse 24 hours a day. Again, the whole idea is to keep patients at home predictably, right? We know of many services, they work with lay people and their clients bounce back into ICU all the time, or even worse, they might be passing away. And we have enough evidence to confirm the claims that I'm making here. I'll give you another example. So one of our clients is at home on a tracheostomy with ventilation. He's got motor neuron disease. So before he ended up with a tracheostomy at home, he was at home on BiPAP, right? And that brings me right back to the aspiration risk. So when he was at home on BiPAP, he had no nursing support. The work was done mainly by the family, and he ended up with an aspiration pneumonia. That aspiration pneumonia got him into ICU. In ICU, he got ventilated with a breathing tube, and he couldn't be weaned off the ventilator, and then he ended up with a tracheostomy, and that's when we started working with the client, and we took him home within 4 weeks. But please keep in mind that the aspiration pneumonia might have been avoided if an intensive care nurse had been there to begin with when he was on BiPAP. So it's also about prevention. It's not only about cure, it's about prevention as well. The last thing someone on BiPAP needs is an aspiration pneumonia. That is the last thing that someone needs, So, but to come back to the original question, how long can you live on BiPAP or CPAP at home? It's really a case of, how long can BiPAP or CPAP be tolerated? Is the next step, for example, is the next step to needing a tracheostomy because BiPAP can no longer be tolerated? So I'll give you an example, and whilst it's a little bit left field, you will get the idea. So this morning I was actually talking to a client who has their 74-year-old mum in ICU on BiPAP with COVID pneumonia. So she's on 100% of oxygen. She actually sent me a picture. She's on 100% of oxygen on the BiPAP. She's on IPAP of 16 and EPAP of 12 with a rate of 20 breaths per minute. So the hospital is telling her that, she can no longer tolerate the BiPAP. They're already maximizing the support, 100% of oxygen. You can't go any higher than 100%. So they're now telling her she's either going over to intubation or she may not survive the episode. So, in this situation, we did recommend that they should intubate her, assuming that they want everything to be done. That was our recommendation in the context of that we assume that her mother would want everything done. But anyway, so the same could happen in a home care scenario where, someone can no longer tolerate the BiPAP. It's too tiring for them. The support demand is going up, oxygen is going up, oxygen demand is going up, pressures are going up, maybe tidal volumes are dropping down because there might be resistance, there might be infection or whatever. That's when you would go on to a breathing tube and potentially a tracheostomy, and then you have more options of managing ventilation and the ventilation at home in particular. So in terms of, again, life expectancy, some of our clients have lived at home for many years on BiPAP, but again, we've also had some palliative care situations at home where patients go home on BiPAP and they want to have palliative care at home. They do not want to have palliative care in ICU, of course. That's when they engage our service. Also, what we've done over the years is we've taken patients home that had a quote-unquote one-way extubation in ICU. They went home on BiPAP to have some quality time with their families, and then, the BiPAP was removed and palliative care was started, and nature was taking its course on those patients. But again, it was very rewarding, or this is very rewarding work, because patients can at least pass away in an environment where they want to be. It's not, the end of life situation is not dictated by the hospitals. It's just something that families have opted for, and that can be facilitated by our service intensive care at home. If I keep coming back to this example from a minute ago about where I said one of our motor neuron disease clients had an aspiration pneumonia while he was on BiPAP at home, just to give you another example there, we are currently working with another client. He's a muscular dystrophy client, and he was looked after 24 hours a day by support workers on BiPAP. And again, he had an aspiration pneumonia that got him into ICU, and is now confined to an ICU bed since the last 6 months, right? Again, I believe this is something that could be prevented with our service, intensive care at home, because it's a higher level service. Once again, nobody at home on BiPAP or on CPAP should be looked after by support workers, by general registered nurses, or by families, because they're simply lacking the skills and the expertise to do so. And again, what I'm saying here is evidence-based. If you're going back to the mechanical home ventilation guidelines that are evidence-based, it's clearly saying there that only intensive care nurses 24 hours a day can look after patients at home on mechanical ventilation invasively or non-invasively. Now, another question we're getting quite frequently, I gave you this example a minute ago where I mentioned that I was talking to a client this morning who has their mother in intensive care, and after COVID, she's on 100% of oxygen now, on the BiPAP mask, and we're getting a lot of questions there. How long can someone live on BiPAP in ICU? I think it ties right in with this question. As long as they are BiPAP tolerant, they can live with BiPAP for a long time to come. But again, it also depends on what's the underlying issue. In a COVID situation where if COVID is sort of getting worse, the only option really is to intubate. There are some situations, maybe for patients with COPD, asthma, where they don't need intubation as long as they are CPAP or BiPAP tolerant. They can live on it for a very long time. And again, if they're stuck, if your loved one is in a situation like that in ICU, that's when you should contact us so we can help you taking your loved one home. Now, there is a distinction that I need to make. Again, we have many inquiries where someone goes into ICU just for a couple of days of BiPAP. It's a new situation. They've never been on BiPAP before. And then we have people contacting us, can you help us take our loved one home on BiPAP now? And we say, well, technically we could, but the question always is, how quickly can they come off the BiPAP? Because, if they stayed in ICU for another week and they can come off the BiPAP, it's no point really to start looking into intensive care at home, because if they get off the ventilator, then it's so much easier, to keep them in ICU for another week and then get them to a ward and then get them home, because it's so much easier. It's so much easier to take them home without a ventilator. Now, you just need to give me 1 second. I do apologize. I have to quickly respond to a text that can't wait. I do apologize. Okay, sorry about that. So that's a situation for patients in ICU, where we can 100% help you get your loved one home if they can't be liberated off the BiPAP and also if intubation is not needed. Now, when someone is in hospital and you want to go home on BiPAP, they often need to have a sleep study to see what their breathing pattern is with arterial blood gases. And with arterial blood gases, and then you can adjust the ventilator, and then you can take them home. So that's how that, generally speaking, works in terms of transitioning home. If you are in Australia again, you should contact us. The NDIS is funding most of our services, but also organisations such as the TAC, the Transport and Accident Commission in Victoria, or ICARE in New South Wales, or the DVA, the Department of Veteran Affairs. That brings me to another client that we looked after at home on BiPAP. Again, a fairly young man at the time with regular seizures. And again, needed 24-hour intensive care nurses because he was on the BiPAP, he had regular seizures, he was desaturating very quickly, had an unstable airway regularly. And another client that we are going to start soon is a client that has end-stage lung cancer, right? Is on the BiPAP 24 hours a day, again, doesn't want to go back to ICU. And that's where we can help with managing the BiPAP, managing all the pain medications, and managing just the overall care of such a complex client. Again, if you're finding yourself in a situation like that, you should definitely contact us. We can help you, send you nurses. And if you're worried about funding, you should also contact us. We can point you in the right direction how to get funding, whether it's, again, through the TAC, the DVA, or the NDIS in particular. You should contact us. Okay, so that's giving you an overview, if that makes sense. Now, what questions do you have? I know Teresa just asked a question. Oh, thanks for all your help. It's a pleasure. It's a pleasure, Teresa. I hope that things are improving for you and your family. And it's nice to see you here. Now, if you are an NDIS participant, or you have a family member that's an NDIS participant, again, you should definitely contact us if you have a loved one on BiPAP, whatever their underlying disabilities, and you should not be put off by the rhetoric that you hear potentially from NDIS support coordinators from the NDIS that there won't be any funding. That is not the case. We wouldn't be in business if the NDIS wasn't funding, and if I was saying was not accurate. So you should definitely contact us. And if you're in the US, you should contact us as well. We can hopefully point you in the right direction, what to do next. We are engaging with a couple of service providers in the US at the moment, but we can also guide you around what to do when you're in ICU. You should absolutely contact us either at Intensive Care at Home on one of the numbers on the top of our website, or at intensivecarehotline.com, and contact us there as well on one of the numbers on the website. Teresa, you're saying your dad pulled his tracheostomy out all the way during the night. Sorry, just need to bring up the message. It's disappearing. They were able to get it in timely, but they can't tell us if they used the same trach or a new one. What should we do? Teresa, I would be very surprised if they used the same one. Once it's out, it's deemed unsterile, it's deemed dirty. So I would be very surprised if they put in the old one. They should have spare tracheostomies at the bedside, which means, a skilled nurse would just pull out a new tracheostomy, would put it back in, would hopefully do it sterile, and there's no need to do anything else really, besides possibly doing a chest X-ray, just making sure it's all in place. I would ask, have they used a new one? Have they done a chest X-ray? Those are probably the two most important questions. Now, you're saying they you are saying they had to take him off air mist after 48 hours and now back on CPAP. Is this common? And he's been very sleepy and out of it all day. Great question. So what I can see there is when you say he pulled out the trach, I hope they recognize it pretty quickly. Some of it might depend on, you know, how long was he without a trach? Is that why he's potentially out of it? So you would hope that they would have picked up on it pretty quickly and that they would have, you know, done all the right things within minutes. But those might be your next question. How long did it take them to A, find out he pulled out the tracheostomy, B, how long did it take them to put it back in? If he's now back on CPAP, it might be a sign that he had the trach out for a little longer than they want to admit, because he might be simply exhausted. Okay. The other thing that might have happened, and again, I'm speculating here a little bit, the other thing that has happened is so maybe they've given him sedation when they reinserted the tracheostomy. If they've given him some sedation, that may be one of the reasons why he's now back on CPAP. And again, if he's been very sleepy, what I said before, for example, I mentioned carbon dioxide. If you had the trach out for too long, maybe his carbon dioxide went up and that's why he's sleepy. Maybe a blood gas might be something they would want to look into. So you're saying they did a CT scan of the brain, you're waiting for results. Right. So why would they do a CT scan of the brain? I tell you why they probably would. Probably would do that because they are worried that the trach was out for too long and that they didn't put it back in quick enough, and they were worried that there might have been some hypoxic injury or hypoxic episode. That's my explanation from a distance. With the information that you've given me, there could be other things as well, of course, so that's very incomplete. They've given him Cyprexa 2.5 for agitation last night. Was that before or after he removed the trach? You know? Was the Cyprexa given before or after the trach removal? And this is also why, you know, this happened in a hospital, obviously. But these are also the reasons why at home, again, keep coming back to the mechanical home ventilation guidelines, why at home our clients need an intensive care nurse 24 hours a day, because things like that happen. Patients might remove the tracheostomy, right? And then you need to know what to do in an instant, right? That's a perfect example. So if this happens in a hospital, this can happen at home. So they've given him the Cyprexa after tracer, okay? So if they've given him the Cyprexa after the tracheostomy removal, that probably means he was very agitated to begin with. And now the question is, has that Cyprexa made him too sleepy, and is that why he's gone on CPAP? Hard to say, but it might be one of the reasons. Having said that, Cyprexa 2.5 is not, it's not a lot, but it's also, it can kick in very quickly. And if it kicks in very quickly, you know, it can knock people out. It can have a knockout effect. Having said that, it's also short acting, so, you know, people might come out of it reasonably quickly as well. That's my experience there. Now, if anyone else has any questions, please type them into the chat pad now. Now, also, if you want to dial into the show and want to ask questions on the show, I'll give you the numbers now. If you're in Australia, call 041 094 2230. That's again for our Australian viewers, 041 094 2230. For our American viewers or Canada, 415 915 0090. That's again 415 915 0090. And for our UK viewers, 0118 324 3018. UK 0118 324 3018. Now, so the questions that have come through. Tracer says he's very sensitive to any meds. Yeah, I'm sure he is. I'm sure he is. Anyone in ICU is incredibly sensitive to any changes. It doesn't take much to upset the status quo in ICU. Patients are incredibly sensitive. Helene, nice to see you again. You are asking, can excessive use of BiPAP cause a pneumothorax, air around the lungs? If not, what are the causes for this condition? Yeah, absolutely, Helene. I don't know whether you were here from the beginning. This is something that I mentioned in the beginning, that I wouldn't say it's so much the excessive use of BiPAP that can cause a pneumothorax, but the use of BiPAP can 100% cause a pneumothorax. So, for example, what I mentioned in the beginning is that if patients are not managed with intensive care nurses or with highly skilled nurses, and they're not picking up on, secretions on the lungs, on, for example, if someone is on BiPAP and a nurse has a listen with a stethoscope to the lungs, and for example, there's no air entry on the left, but there's air entry on the right, you got to wonder what's happening. Is there a pneumothorax, for example? And that needs to be picked up on very quickly. So the risk for someone on BiPAP to sustain a pneumothorax is very high, right? Because the pressures that go into the lungs are very high, right? So it's as simple as that. Now, Teresa, you're asking, can a nasogastric tube be used on CPAP? Yes, absolutely. There's no reason why a nasogastric tube can't be used on CPAP or on BiPAP. So, and Ellen, you're asking, what if not, what are the causes for this condition? Can excessive use of BiPAP cause a pneumothorax? So that's, the answer is yes. If not, so yeah, the answer is yes. I hope that answers your question there, Helene. Now then we've got TIS here. Hi Patrick, hope you're well. It's Leroy Leone's nephew. Leroy Leone's, I remember the name. Leone's nephew. Mom has done a recent blood gas. Leroy Leone's nephew. I remember the name. I can't quite point my finger to it now. Anyway, Mom has done a recent blood gas, and her PO2 is 7.6, and her PCO2 is 8.04, and her pH is 7.372. Also, SpO2 is around 88 and above. Her finger reading shows mid-90s saturation. Those are not great numbers, TIS. Those are not great numbers. Those are not great numbers at TIS. 88 of saturation is pretty poor. PCO2 of 8.04 is too high. PO2 of 7.6 is too low. So got to give me more information to look for a remedy. Now, Tracer, you're saying they have him unhooked all day because he's on CPAP. What they told us, I follow through on that. I know his albumin is 2.5. They have him unhooked all day because he's on CPAP. What they told us, I follow through on that. I know his albumin is very low. He probably needs an albumin infusion. When you say they have him unhooked all day, what do you mean by that? What do you mean by that? Leroy Leone's nephew. TIS, are you in London? I'm just trying to think who's Leroy. I think I do remember Leroy. I think I was talking to the family there earlier in the year. But I can't, have to look through my list of names. So Teresa, what are you saying when you mean they have him unhooked all day? I don't know what you mean by that. I'm from Bristol. Yes. Leroy. Leonis, yes. I think I remember speaking to Leroy's mum. Yeah, okay, great. Yeah, you're in the UK. Yes, I remember now. Wow, that's in the middle of the night for you. Thank you for coming onto the call. I know it's like 2 a.m. for you or something like that. That's great. They stopped feeding him. Teresa says they stopped feeding him. He was eating puree last couple of days with night feedings. Stopped feeding him. He was eating puree with night feeding. So basically overnight they put him back on the nasogastric or the peg feeds, Teresa. Why did they stop feeding him? What stops them? What stops them from feeding him, Teresa? Now, I'm still trying to find out who Leroy is. I do recall Leroy, but I just can't piece the puzzle together. Was that Emma McCampbell? Does that ring a bell? Is that Leroy? Anyway, Teresa, if you can get back to me. They said CPAP. Okay. But why did they stop feeding him, Teresa? What's the reason for that? The CPAP? The CPAP stops them from feeding him? It may stop them from feeding him because, like I explained in the beginning, there's an aspiration risk. And you're saying he was too sleepy to eat today, the puree. Right, okay. Fair enough. Yeah, you don't, if he's too sleepy, the risk of him aspirating is too high. So then Helene asks, when a patient with ARDS is on BiPAP, is it okay to receive IV fluids? What are the dangers of excessive fluid overload on the BiPAP? Great question, Helene. So many patients, especially during COVID, went on BiPAP to begin with ARDS. That was the first line treatment, right? That often failed, or not failed, it wasn't enough, so they had to be intubated. Did they receive IV fluids? 100% they did receive IV fluids. The challenge for any ventilated patient in ICU, in particular in the acute phase, is you don't want to fluid overload them. If you do fluid overload them, the first organ that would be impacted is the lungs, okay? So therefore, you need to keep the lungs dry. Okay, so that's why in ICU, but also at home, what we do with intensive care at home, we maintain very strict fluid balances and we measure fluid balances. Okay, so, you know, and that's what we do. What are the dangers of excessive fluid overloaded on the BiPAP? Well, the danger is simply that the next step is intubation. That's the danger with fluid overload on BiPAP, right? Again, someone on a ventilator, the last thing you want is for them to become fluid overloaded. That's the last thing you want. Okay, Wendy, nice to see you again. I think you've been here before as well. My mum just got off the ventilator Monday for the second time in a month and a half time. She has a one-sided paralyzed diaphragm and her CO2 levels get in the 90s and they have to ventilate. Wow. They are wanting to send her home Monday with hospice. They say they can't do any more for her. She's only 62. Wendy, why is your mum on the ventilator in the first place? Does she have a tracheostomy? That would be my first question. If you can answer that, that would be great. TIS, mum had lung failure and we advocated for her. We also spoke on WhatsApp in meetings and now she's at home. Okay, yes, of course. Now I know who you are, Leroy. Yes, of course. Now I know who you are. Your auntie is Leonie. Yes, okay. With you now. Sorry about that. Mom had lung failure and we advocated for her. We also spoke on WhatsApp in meetings. Yes. Now she's at home on NIV. Okay, now I need to go back to some of your other questions because now I know who you are and now I remember your mum's situation. Yes. Leroy Leonis' nephew. Mum has done a recent blood gas and her PO2 is 7.6 and her PCO2 is 8. Okay, yes. Leroy, did she have a sleep study as part of that? Now I'm piecing together the puzzle. Do you know whether she had a sleep study as part of the arterial blood gas? Okay, so now, Tracer, oh, hang on, before I come back to Tracer, Leroy, you're saying she's on oxygen concentrator of 60, that's when she relaxed, and she has to be switched to 80, that's when moving around, and yes, that's right. Yes, but with the blood gas, Leroy, did she have a sleep study in hospital? Do you know? Okay, Tracer, you're saying, now Dad has a huge edema purging out of his left side of the stomach. They're giving Lasix, only has physical therapy 1 time in 7 days. LTAC is horrible, have to be on top of them. Yes, I know. Purging out of his left side of the stomach. They are giving Lasix only as physical. Yeah. Problem with your dad, Tracer, is they're not doing what they're supposed to be doing. We know that LTACs are horrible. Okay, Wendy, you're saying her CO2 was too high, but she has refused the permanent trach. She also has issues keeping the BiPAP mask on, and my dad has a hard time keeping it on. She's also on constant oxygen. She also has AFib and congestive heart failure on TI on top of it all. So Wendy, what you're saying is your mum doesn't have a trach and she doesn't have a breathing tube. So your mum is ventilated with a BiPAP mask. Is that what you're saying? Okay, Helene, can BiPAP machine cause collapse of the lungs? No, I'd say not so much. If anything, it reverses a collapse of the lungs. So if you've heard of the term atelectasis, right? Atelectasis is a collapse of the lung alveoli. And if anything, the BiPAP opens up those collapsed parts of the lungs. It opens up the alveoli, right? I hope that answers your question. So Wendy, really, I need to find out from you whether your mom has a breathing tube or whether she's just on BiPAP, because it all depends on that. Because if they want to send her to hospice and she doesn't have a breathing tube, if you want her to continue treatment, she needs to be intubated most likely, and then you can see whether she's improving or not, and then you can take the next steps. Okay. Thank you for all your questions. Keep them coming. Seems like we're on a roll. Leroy, really need to know whether she had a sleep study with all of that. And what did they say? What was the outcome from the blood gas? What did they change because of it? Wendy saying that is correct. Her first time on the vent was for 11 days and this second time was 8 days. Just BiPAP right now. She doesn't want to go to a long-term facility. Wendy, she being intubated doesn't mean she'll be going to an LTAC, okay? But what you need as a starting point you need her to be intubated to avoid hospice, if that's what you want, if that's what she wants. You know, I can't tell you what is right for your mum. Only you and your mum can determine that. But you need to know about the options. The options are intubation, potentially a trach, but get her intubated first and see whether she can improve from there. That's the best that I can recommend for you now. And you are saying in your first message, you're saying, Wendy, that she got off the vent for the second time in a month and a half. Also, if her diaphragm is paralyzed, yes, very important, Wendy. If her diaphragm is paralyzed, ask them, have they considered a diaphragm pacer? Right? Some patients even with a C1, C2 spinal injury, they have a diaphragm pacer, and that can actually initiate some breaths. Right? Ask them that very question, have they considered a diaphragm pacer? It sounds to me like as part of the stroke that her diaphragm is paralyzed, at least part of it. So ask them have they considered a diaphragm pacer? It requires surgery, but it could resolve some of the issues there. We have looked after clients at home with diaphragm pacing if they have a C1 or a C2 spinal injury. It is an invasive surgery, but I think it's sort of minimally invasive. Ask them that very question. Okay, keep the questions going. I have about another 10 minutes before I need to wrap this up. I believe her heart issues are keeping them from doing any surgeries right now. That's what Wendy says. Look, you got to ask the questions. Do you know if she's on any inotropes? Inotropes or vasopressors? Wendy, do you know that? But even so, you should be asking regardless. Helene, is 72 hours straight too long for a patient to be denied food, water, or break from off the BiPAP? That's a great question, Helene. There are situations where I've looked after patients in ICU that have been on BiPAP, have been on high levels of BiPAP, and you could barely take them off because they just couldn't cope. But for whatever reason, you wanted to keep them off intubation. And the reason we wanted to keep them off intubation was simply that we thought that we had reason to believe that if we intubated the patient, they would not survive. So then the question came, do we need to keep them off food, water to minimize the aspiration risk and keep them on the BiPAP and not intubate them? It's a very difficult question to ask, and it's an ethical question, if anything. But in those situations, we had to weigh up, okay, what's the risk versus benefit, right? Do you want to deny people food and water, but do you keep them alive and then deal with food and water down the line? It's a difficult question, but yes, I have seen those situations. And it would have been 48, 72 hours. I hope that helps, Helene. Now, Wendy says, your mum is not on inotropes or vasopressors. I will certainly ask them, though. Thank you for your time. Sure. Ask them about the surgery. Teresa, my dad's CO2 was also elevated. I heard last night, but better today. Want to say 31. 31 is good for CO2. Probably if CO2 was up, they put him on the CPAP. The CPAP probably brought the CO2 down. Leroy, what happens in a sleep study? She had an appointment with the Dream Clinic around June. So what happens in a sleep study is the sleep pattern of a patient will be assessed during a sleep study. They're hooked up to monitoring, and then out of that sleep study might come that they're doing blood gases during the sleep study, and then they might adjust the BiPAP. So my question is, as part of that, as part of the arterial blood gas and potentially a sleep study, did they adjust the BiPAP settings? I would almost say yes, but that's the question that you need to ask. And she has had this blood gas about a week ago. So I'm actually wondering, did she have a sleep study in June? Did she then have an adjustment of the BiPAP between June and now? And did she now have another follow-up blood gas? That's what I'm wondering, Leroy. And they've done this because there were concerns about her carbon dioxide because she was getting headaches and falling asleep, but she does like her late nights watching Netflix series. Yes, that's probably exactly what's happened. Her CO2 was going up. She was getting tired. She was getting drowsy. They did a sleep study. They did an arterial blood gas. They readjusted the BiPAP settings, and now they probably did a follow-up blood gas to make sure it's working. That's my theory. Ask your mum, ask your auntie whether that's what's happened. Oh, and they have a memory card attached to an NIV machine. Yeah, most NIV machines now have a memory card just to keep track on the parameters. Right. So you see, Leroy, that there you go. There you go. So that's great. That's great. Okay. Right, that's exactly what's happened. Okay, great. That's good to hear. That's good to confirm. Yeah, that's great. Yeah. And if I may just say, Leroy, just for everyone that's on this video, I think your mum was the prime example where, the ICU wanted to give up. They literally wanted to kill her. And we stepped in with some advocacy, and, your family was great. and we turned it around. It was a real success story, by getting your mum out of ICU, by getting her home. And how many times have you heard from the ICU team she was dying and she won't have any quality of life? And there you go, 6 months later she's at home, and yes, there are issues, but she's at home and she's alive. That was a great story with your mum. Helene, are handcuffs, restraints mandatory or optional for a patient on BiPAP? Who makes that decision? Great question. Helene, I think it very much depends on state legislation. I believe you're in Florida from memory. It probably depends on state legislation. It's different. I know in the UK, for example, restraints are forbidden. You know, here in Australia, they can be used. So it really depends on the jurisdiction. I can't answer that question. You have to find out what's happening on a state level. Or Georgia. Got to find out what's happening on a state level. I wouldn't know. There are different rules in different jurisdictions. Okay. Now, slowly wanting to wrap this up, but keep your questions going in the meantime. I will be going again live next Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 8:30 p.m. Eastern Standard Time in the US. Same time again next week, Saturday, US time, 8:30 p.m. Pacific time, 5:30 p.m. on a Saturday, 10:30 a.m. Sydney, Melbourne time, and I believe that's 1:30 or half past midnight in the UK. Now, we have more questions. Wendy says, they have used restraints on my mum, we were in Georgia. Now, Wendy and Helene, just because they were using restraints doesn't necessarily mean it's legal. Okay, I just put that in there. Just because they use it doesn't mean it's legal. You just got to check what's in your state. Well, thanks, Leroy, for acknowledging that. It was an absolute delight working with you and your family at the time. Helene, how often should blood gases be tested on BiPAP? Great question. Probably depends on how acute a patient is. So, as an example, this morning when I was talking to this lady who has their mum on BiPAP on 100% of oxygen in ICU with COVID pneumonia, I would think that in a situation like that, they would be doing 3, 4, 5 blood gases a day, potentially even more. If someone is stable and they're using the same settings over a period of time, it's probably enough to do 1 blood gas a day. Now, with our clients at home, we don't do blood gases, but bear in mind they're chronic clients and they've been on BiPAP for a long time. They might do a sleep study once a year, and that's when they do the blood gas. So in hospital, if patients are unstable, 100% you need to do it very regularly, but it really depends on how stable or unstable a patient is. Now, Wendy, I know they said they did not like using them. They have a sitter in the hospital room with her now to make sure she keeps the BiPAP mask on. That is the preferred option, Wendy. And if they are now using a sitter, I'm almost bound to say it's not legal to use restraints. Otherwise, they wouldn't be using a sitter. That's my theory there, but I could be wrong. I don't know the ins and outs of state laws in Georgia. Yes, so Leroy, great to see you again here. Okay, so we'll do another live stream next week around the same time. Still have a couple of minutes left. If you have any other questions, keep them typing in here and I will get to them. I haven't decided yet what the live stream next week will be, but it'll be a topic that will be of interest for everyone again. Watch out for the topic when I announce it later in the week. If you have any suggestions for a topic, please just shoot me an email to support@intensivecarehotline.com. And I will work with topics that you are interested in as well. Most of the topics that I am selecting are questions that we're getting quite frequently. But if you have any topic that you think we haven't addressed here, please just keep them coming. Now, I also, obviously, if you have a loved one in intensive care and you want to go home, go to intensivecareathome.com. If you're in Australia in particular, we are servicing Brisbane, Sydney, Melbourne, Adelaide, Perth. Please contact us. Also, if you need funding. If you're in the US, contact us as well. If you have a loved one in intensive care and you need consulting and advocacy, go to intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. And if you need help for intensive care at home, send us an email to info@intensivecareathome.com. Also, check out our membership for families in intensive care at intensivecaresupport.org. If you need a review for medical records, we can help you with that as well. While you're in ICU, if you have a loved one in ICU, we can help you reviewing medical records while your loved one is in ICU, but also outside of ICU. Again, contact us for that. Now, Helene has another question. She says, if a patient is no longer under carbon dioxide duress, is there any reason to keep a patient on BiPAP? Yes. So whilst BiPAP is very good for to bring CO2 down, for example, again, probably coming back to the lady that I spoke to this morning that has their mother in ICU on BiPAP for COVID. We checked the blood gases. The CO2 was actually pretty good, but the PO2 was pretty crappy, which is also then another sign that she probably needs to be intubated. Most CO2 issues can be managed on the BiPAP, but PO2 issues may not necessarily be managed on the BiPAP, if that makes sense. Also, if you like this video, I appreciate if you give it a thumbs up. If you find it valuable, share it with your friends and families. Subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. And click the notification bell. If there are no other questions, I'd like to wrap this up, and I really want to thank you for coming on to the show. Tell everyone about intensive care at home and intensive care hotline, and I will talk to you next week. Thank you so much. Take care.